as the inflammation goes on, the appendix can start to become gangrenous and necrose. And so in this case, we certainly have an enlarged appendix, but it's fairly featureless. Look at this normal loop of distal ileum right here. You can still see the bowel layers. So we know it's not a technique problem, but the appendix immediately posterior to it is enlarged, losing mucosal detail, very patchy blood flow in this child with acute gangrenous appendicitis near the point of perforation. Again, no hyperemia. Okay? Don't be dissuaded by that. This is a completely necrotic in a larger child, infarcted appendix, completely gangrenous, so we wouldn't expect blood flow. And in this case, we really lost all mucosal detail. There's just little bubbles of gas here in the lumen, probably actually in the wall of the appendix. Lots of inflammatory change in the surrounding fat, and this child had a completely necrotic and early perforated appendicitis. It really is important to see the whole thing. You can have appendicitis just located to the tip, as in this particular case, the proximal appendix was normal. There was an obstructing lith roughly here, and so the appendiceal tip is dilated. The patient was exquisitely tender there, a little bit of inflammatory change around, and in this machine, this was hyperemia back in the day for this particular scanner in this child that had appendicitis just located to the tip. Look around for appendicoliths, particularly in the day of laparoscopic appendectomies. You don't want to leave an appendicolith behind. If they leave it behind, the child will almost always get an abscess and require a second operation. And liths can be of various sizes and various degrees of echogenicity, from rather small with a minimal posterior shadowing to very large stones, indeed, which obstruct the entire lumen near the base of the appendix. And lastly, always look down at the cul-de-sac for abscess. Again, now that you've made the diagnosis, now our job is to try to inform the surgeons and the clinicians what sort of treatment is possible. If you have a large abscess or at least have concerns about that, that child may benefit more from interventional drainage and an interval appendectomy after the abscess and infection has cooled down. If you don't see an abscess, then the surgeons may elect to do a primary operation. So overall, papers are fairly consistent. The sensitivity of ultrasound for diagnosing appendicitis is roughly 85%. Using color Doppler, I think, helps. Looking for those inflammatory changes in the right lower quadrant also helps. False negatives can occur with a focal or very early appendicitis. If it's retrocecal, if it's perforated and decompressed, it may be more difficult to find. You can have false positives with Crohn's disease or Meckel's. Meckel's I don't feel bad about. That would still be a surgical indication. But occasionally you can get Crohn's disease, as this patient has here. And this is a thickened loop of distal small bowel, markedly thick, lots of inflammatory changes around it. Lymph nodes, again, if you scan around, you'll see other abnormal loops of bowel. You won't just find an abnormal appendix. So this should not typically be a major complicating issue. Intussusception is another very common cause of abdominal pain, or at least and is a concern to the clinician. It's an invagination of the bowel into itself. Ileocolic, occurring near the ileocecal valve, is the most common. Most of these kids are younger than 2 years of age, and it's very uncommon less than 3 months of age, primarily because lymphoid tissue, the Peyer's patches in the distal small bowel, typically are the lead point after a viral illness, and below 3 months of age, typically children don't have well-developed enough lymphoid tissue to act as a lead point. Over 95% of these are idiopathic. Occasionally you can have duplication cysts or a Meckel's diverticulum or some other mass act as a lead point. Those children are usually older. The classic triad of intermittent abdominal colicky pain, mass, and bleeding with these so-called current jelly stools, while classic, like many classic triads, is present in a minority of cases. Plain radiographs, I think, still have some role in looking at the child with abdominal pain. In this particular patient, not a grossly abnormal bowel gas pattern, but there is some slightly dilated loops of small bowel here. You have to get some sort of a decubitus film or prone image to get air to go up into the ascending colon. In this case, we see this rounded soft tissue mass, which is the intussusception. Now, while plain films are still rather useful, ultrasound has terribly high sensitivity and specificity for intussusception. It's probably as close to the perfect test as anything we have in pediatric ultrasound. If you know what you're doing, you can easily see these intussusceptions. They have a pseudo-kidney appearance with multiple layers. Several authors are looking at whether it's worth assessing bowel viability to see if children are candidates for intussusception reduction, either by fluoroscopic or ultrasound means. We use a high-frequency linear curve probe. You really need to search for the entire abdomen. Most will be found on the right side. You can use gentle compression, but again, when people are starting out, they worry that the colon is typically full of gas. How will I see it if it's there? But remember, if you have this big mass which is invaginated into the intestine, it's going to displace all of the gas, and you will see the mass, and it's really not a problem. So in this particular child, here is a longitudinal view. Here is the kidney. The child has a little bit of free fluid. This is the pseudo-kidney appearance, regular kidney, pseudo-kidney. In a transverse image of the same patient, here's more of the target or bullseye sign, again adjacent to a normal kidney. Another picture here, this is the intussuscipiens, the recipient, or the thing the bowel invaginates into. Here is the intussusceptum, the inner part which is coming in, and you can often see this echogenic material. This is the mesenteric fat that supplies the intussusceptum, so it's the fat that goes along with this loop of bowel. You may see lymph nodes, okay, not the same case, but here are little lymph nodes, a path specimen showing the intussuscipiens, the intussusceptum with associated fat, and in this case a mesenteric node probably acting as the lead point in that case. Color Doppler, the slightly older study, but it's borne out by newer research as well, that if you see blood flow that indicates bowel viability, and that indicates that reduction could certainly be successful. Absent blood flow, to me, is not a contraindication to try an intussusception reduction, because again, if you don't try it or are successful, the child is going to need an operation. So in my opinion, there's little to lose. It's still worth looking at the blood flow to see if the bowel is viable, because that can certainly indicate that you may have problems afterwards and that the parents and surgeons should be aware of potential complications. So the treatment again is a reduction enema. We use air in our institution. I think it's safer than liquid media. The success rate should be over 90%. That really depends upon the duration of how long the disease has been there, whether or not there's a lead point, and again, if we are unsuccessful, the child's going to need surgery. So just a couple of fluoroscopic spot images from a reduction. Here is the intussusception up here. We are filling the colon with air. We are pushing the intussusceptum back. Here we have pushed it back to the ileocecal valve and finally popped through, and you can now see filling of loops of small bowel and disappearance of the mass in that successful reduction. If they are not successful, they will have to have an operation. So here is the cecum, and here's the surgeon pulling out the distal small bowel from the ileocecal valve. And while this particular bowel is a little bit dusky, it certainly pinked up. There was no necrosis, and the child did not need any sort of bowel resection. Intussusceptions can recur. We usually quote an incidence of roughly 5% to parents. In this particular child, on August 10th, came in, had classic intussusception findings, had a successful reduction, went home, had recurrent symptoms, and came back in the next day with the exact same ultrasound appearance. We looked again, did not find any pathologic lead point, which is something you probably should do in a child with recurrent intussusception, although most won't have it. This particular patient had another successful reduction and then had no more further problems.